change now and kind of move into sinus realm. These are all just, if you're not doing these in your practice, I know that it was mentioned in the breakfast this morning about doing rhinoscopies and endoscopies and how allergy and sinus work so closely together. So Dr. Thompson is going to be our disembodied voice from behind. He is going to be kind of walking us through some of the CT scans and maybe even some more challenging CT scans. So, Dr. Thompson.
You guys often see is that we get a scan, it looks pretty good. They got a great story. We know they have recurrent acute sinusitis. They're good candidates. But UHC requires us to photograph the scans so that they can see a certain amount of mucosal thickening, which I don't think is a very appropriate way of evaluating a sinus patient just based on one image or even photographs of one image. But anyway, that's their protocol, and that's what we have to live with. So you'll see me request another scan when the patient's more symptomatic so that we can demonstrate to United that, yes, this person really is having sinus mucosal thickening when they have flare-ups, and that in between they may look okay. So this was an example of a patient that was in that situation. This was her first visit. She had a big retention cyst in the left maxillary, you can see here, some septal deviation. The OMUs were pretty tight, really tight on the left. On the right, narrowed, a little howler cell kind of impinging on the drainage pathway there, and another one here. But not enough to get United motivated to approve, so we got a scan later, and sure enough, that left one that was more narrowed was completely clogged. There's chronic mucosal thickening here on the maxillary ceiling, and then surrounding that cyst, of course the cyst didn't change, but you can see there is chronic mucosal thickening sitting underneath it. And then on the right, there isn't a whole lot of change. I thought there was a little bit down here, but the left ethmoid is really significantly inflamed at this point, and it extends into the left frontal. The left frontal drainage pathway is clogged up. Some more right anterior ethmoid. So this was enough for them to approve it. Obviously, it's a pain in the butt for the patient. When we do this, we offer the patients to come in without an appointment or anything so that they don't have to spend a lot of time out of their day making this happen, to make it a little bit easier on them, but that's an example. Here's another one. And I think this is also kind of a pictorial example of what recurrent acute is. You know, you see patients with scans that aren't overly impressive. It's hard to get excited about them, but it's just a picture in time. And these patients who are having 3 or 4 or 6 of these infections may look great in between the infection, but at the time they look like any other chronic patient, and we really have to think about the fact that a CT scan on any given day is not going to be representative for their entire year's sinus history. So this was another patient that had a little bit of thickening here in the left maxillary, but not an overly impressive scan, other than the fact that the OMUs are really hard to see any patency whatsoever. There is some mucosal thickening right there at the entrance, which probably is just kind of sitting there dormant, waiting to sprout. And then on our next image, we get some frontal thickening. I thought there was a little bit more in here, maybe down here, but that was enough to get United approval for that case. Again, kind of painful for the patient to come back in, but if you explain to them what we're up against and that, you know, the next flare-up as early as they can to come in most cases we can catch it. A lot of times we lose them to follow-up because of this, and I have a feeling that that's plays right into United's grand scheme. The next one is kind of a series of patients that, well, this is another one that exhibits that recurrent acute nature. So her scan here, you can see a ton of sphenoid disease. A little bit of maxillary mucosal thickening here right at the OMU. Similar on the right, it's really tight, hard to really see any sort of patency. A lot of ethmoid extending into the frontal. She's got mucosal thickening there. But then on this scan, her sphenoid looks good. There was no treatment. There's a little bit of thickening at the ostia. You can see it's a little narrowed right in here. That's kind of the ostia for the sphenoid on the left, but nothing major. But that's a significant amount of sphenoid thickening. These always make me nervous because the sphenoid is next to the optic nerve right here, the carotid artery is there. There's a lot of stuff going on. I don't like to see chronic disease sitting in the sphenoid. But again, it's a testament to the fact that recurrent acute is going to come and go, and you may not catch it on the scan, but it doesn't mean it wasn't there or that it isn't a significant quality of life impairment. Then I was going to show a series. One of the things that's really tough is the decision to treat the ethmoid sinuses. And I know I'm subjective and vague sometimes, so it's hard to really create a protocol to follow as to when to check that ethmoid box to suggest ethmoid surgery. But I look at all these, so if there are ones that could go either way, I'll usually weigh in and let you know. But this was one that there is some ethmoid mucosal thickening here and here, but it's pretty mild, and I wouldn't treat that with an ethmoidectomy. An ethmoidectomy is a little bit more invasive than a balloon sinuplasty, a little bit more bleeding. It isn't a game changer in terms of the recovery or the risk factors, but it does step it up a notch. A balloon sinuplasty is just so minimally invasive and such an easy recovery. So if we're going to do an ethmoid, I do give it a little more thought than the other sinuses because it is a bit more invasive. So this is an example of one that you might see some thickening and think, oh, well, that's pretty significant. I should check that box. And you probably should, because if you check the box and I don't think it's necessary, I won't do it at the time of the procedure. But then you escalate it to a little bit more disease. This one had some really significant anterior ethmoid. So it's a bit isolated. The rest of the ethmoids look okay, but this is going to be a problem. If that isn't addressed, then there's no way this frontal is going to drain. So dilating the frontal sinus will help, but this one I'd be really concerned that if we didn't open this area up here, that the frontal dilation may not persist, that this disease will just kind of sit there, and then after the frontal is opened, it may take weeks or months, but that residual nidus of disease may kind of rear its head down the road. I've seen a few of these where I thought, okay, well, let's be less invasive, let's not do the ethmoid, and sure enough, it comes back to bite me in the butt. A year later, 6 months later, they have disease again, and it appears that what was left in the ethmoid has now kind of extended back out into the neighboring sinuses. So it's a judgment call. This one would be pretty clear to me because there's so much opacification in that right ethmoid. And then there's the easy ones. This one, there's no question. This is another example, too, of acute. So you see this frothy looking stuff, kind of looks like bubbles probably, but that's probably what it is. So this is a combination of acute and chronic disease together. And this is one that you probably want to treat that day. The rest of this stuff, treating that day is probably irrelevant antibiotics aren't really going to help this much. Steroids are going to help, but it's going to be really brief. But if this person, and this person ultimately went on to get surgery, this is somebody, you see them in the clinic, you want to treat that infection because it is acute, and then get them teed up for the surgery. And of course, when you see this much disease severity, we want to do the prednisone taper 1 week prior to the surgery to get them prepped for the procedure, which is a game changer in terms of my ability to do a thorough procedure and the patient's recovery. Really, they just have so much less bleeding, so much less inflammation, and I think that probably translates into a higher success rate because they just don't have as much swelling. So there isn't a one-to-one correlation. I was thinking about this the other day, but it's close. If the ethmoidectomy is needed, then most of those patients will benefit from a round of preoperative steroids. Again, it's not an exact rule of thumb. Maybe 80% of the time it's true, but I guess it's a good way to trigger that, that red flag. Hey, this patient might need pre-op steroids because I'm checking the ethmoid box. If it's a mild one like the second one here, well, even this one, I'd probably do it. I really do think, if we give steroids to that patient and I go in surgically, this disease is probably going to be at 50% of what it is right here. And it just really makes it easier to get in, find the ostia, and to open the ethmoid. Again, there will be some that are kind of in between. It's moderate ethmoid mucosal thickening and they don't need steroids. But anyway, I think it's a good starting point in terms of how you think about steroids. This one obviously would definitely benefit from it. Okay, this one was interesting because he's got a very, very anterior perforation. You can see the hole right there. If you ever want to measure these things, it's pretty easy. You just hit the ruler, click, click. So that's a 12 millimeter perforation. This one was actually missed by I can't remember who referred the patient, but as you guys always hear me harping, the nasal endoscope is really helpful. I think the patient was examined with either a speculum or just an otoscope. And what happens is this is so far forward that you put the otoscope in, you're already past the perf, so you don't notice it. With a scope, it's pretty obvious because you're looking all the way from the beginning to the end of the nose. And then as far as do we fix these are often asymptomatic. If they are bleeding, whistling, or crusting, then those are symptoms that we start to think about doing a procedure to fix that. Obviously, if the patient's bothered by that, then we'll go ahead and start talking about that procedure. There's also some rules of thumb regarding the size of the perforation. If it's 0 to 10 millimeters, the success rate's pretty high, probably 85–90% chance we can fix it with the first procedure. If it's more than 10 but less than 20 millimeters, the success rate goes down quite a bit. We're probably in the 70% range. May need to do 2 staged procedures or even 3 to get them closed completely. And then if they're more than 20 millimeters, I don't even think it's worth trying. For a couple of reasons. One is the procedure involves taking tissue from the lateral or the floor of the nose and reflecting it into the defect, but keeping its blood supply attached. So it's considered a pedicle flap. So when you move that in, what's supposed to happen is the flap is supposed to adopt the blood supply of the surrounding tissues here, so then you can go back and cut the pedicle. Well, if you've got a gigantic perforation, there's probably really poor blood flow to those areas, and they just never seem to develop any good blood supply, and then the flap just dies when you cut that pedicle. But anyway, 0 to 10, 10 to 20, and over 20 millimeters are pretty good guidelines to consider fixing. And again, you'll see a lot of these and patients won't even know. We were talking yesterday about a patient who I think she was in her late 60s, and she had a perforation, and who knows how long. She'd never had surgery. She reportedly did no inhalant drugs, but she had a perf. It was asymptomatic, and we didn't do anything about it. But there are other perfs, and her perf was very clean. There wasn't a lot of crusting or inflammation. There are some less common disease processes like Wegener's granulomatosis and sarcoid that might cause a perforation, but they're going to be really inflamed, crusty, bloody, swollen. So on a perf like that, you want to get you'll want me to get a biopsy of that just to make sure they don't have one of those less common illnesses. Yes?
Can you make a comment on, if you go back, panning through the CT, when you see the septum where it starts out thin and then gets bulbous, is that mucosal thickening or is that bone?
It's mucosal, yeah. I think, and you know, I haven't seen much written about like this hourglass shape. Is that what you're talking about? Yeah, I have a feeling it has something to do with the aerodynamics of the nose. There's probably something about that shape that makes the air move in a fashion that's more suitable to us in terms of breathing or smelling or something. I don't know, I'm just speculating. But I think that's normal, although you see a lot of these where the swelling is just everywhere and the septum's hugely thick.
So when you go into your procedure, are you going to take care of that extra mucosa or is it just going to come back post-op,
So if it's like this scan here, I probably wouldn't do much about it because I think with some turbinate reduction, there's going to be good airflow. I don't have, well, this is fairly thick. If the septum width is interfering with airflow, yes, I will use the bipolar cautery to vaporize some of the water in the mucosa, just like a turbinate reduction, because that's essentially what this is. It's almost like an extra turbinate on the septum. So yes, I will thin the mucosa but the septoplasty also thins the septum, right? Because you can't see it, but there's cartilage here. You can see where the bone ends. This is all cartilage. It might be about as thick as this area. By removing that, we're going to thin the septum out just by virtue of the septoplasty. So that helps a lot. But yes, I will go back in, Bob, and get some more mucosal reduction with the cautery. Yeah, I mean, I always put that in the dictation that the septum is hypertrophic and that's interfering with the airway. So yeah, I think it's important. Yes?
I apologize to some of these patients for having to ask, but there are more than usual causes of perforation in the nose. About every 18 months, I have a reformed cocaine addict.
Yes.
Is the repair of those holes any different or more difficult than repairing these others?
Only in the sense that you don't know if they're continuing to use the cocaine. If they are, it's going to be a disaster, and if they're not, I think it's pretty similar. As long as they've been off it for, a month or so.
Well, these have been off of it for 5 years.
Oh yeah, then I think they're good candidates. They're probably not any more likely to have problems than a traumatic perforation.
These are a little bit older adults instead of when I was a kid.
Yeah. Yeah. Yeah, I think they're still good candidates. They have typically pretty good blood supply to the edges of the perf.
I used to ask.
Yeah, it does. It's a little uncomfortable at first, but you just have to ask.
I just make a joke out of it and say, well, I have to ask.
Yeah. No judgment.
I'm shocked about every 18 months some nice looking lady comes in.
Yeah, it's not always the people you'd guess.
Doesn't apply to you, but one of the causes of this is, yeah, I was silly when I was in college. Glad I asked.
Yeah, I get a lot of questions too, like how much does it take? And I have no idea. I don't know whether it's 1 or 17 or 1,700. Yeah, that's right. I'm sure we've got a lot of experience. Okay, the reason I chose this scan was because of the adenoid hypertrophy. These are tough, mainly because when you're scrolling back, okay, we're just catching the back end of the septum now. We're into the nasopharynx, and you can see this triangular portion of bone, which I always use as my landmark, because at the point of that is typically where you're going to see the adenoid hypertrophy. And this, it looks like he's got a mulberry back here in the back of his nose. But it will quickly blend with the back wall. So right back here, we're probably looking at the posterior wall of the pharynx. So if you take, let's look at one that doesn't have adenoid hypertrophy. So you see the triangular bone, and this looks pretty flat, but you could probably talk yourself right here into say, oh, there's some thickness there. But that back wall is curved, so you're gradually going to see more and more of this until you're into the mucosa of the back wall of the pharynx. So it can be a bit confusing where the adenoid tissue here is normal, but right behind it starts to look like it's thickened like that right there. So I think the key is just to really, where that point is where you want to start looking. And once it starts to flatten out, you're getting too far behind and you're not getting into where the adenoids are. So if you look back again at this one right there, at the point we're already seeing a whole bunch of tissue, and then it's still there. And then when it flattens out, we're kind of getting behind it. These are tough because you don't always think to look at it. You're typically not going to see this in anyone older than 30, but every now and then there'll be one in their 30s that will have it. Usually it's going to be kids, you know, definitely under 20. But it's probably a good idea to, you know, anybody under 40 just to have a quick glance back here. Again, I'm looking at all these, so if you miss it, it's not a big deal. And if I miss it, then during the procedure, it will be very obvious because the nasopharynx is in very good view when we're doing these procedures because they're just thoroughly decongested. We're injecting epinephrine. The nose is just wide open. Yeah? Both, yeah. So with somebody even over 30 probably, I would do a biopsy and send it in. Or if somebody younger and it looked weird. And then I would just vaporize it. We have a suction cautery that will just vaporize that tissue. So I would take it out, but I would get a biopsy because it's, you know, there are other things, lymphomas can originate back here. It used to be one of the hallmarks of HIV is the adenoid hypertrophy in older adults. You don't make the diagnosis on the scan. We don't see that much anymore for obvious reasons. Yep. Yeah, it's really easy to do in the office. Unlike a tonsillectomy, that's not the same thing, and that we cannot do in the office. And then the last scan here is one that has had a fess before. These are a little challenging because some of the landmarks are gone. He's got big giant openings. You look in here and it looks pretty good. But if you look closely at where the natural drainage pathway is right in here, it's not so good. And so what happened when they had their functional endoscopic surgery, the surgeon got a little bit posterior to the natural ostia. So there's the surgical ostia, there's the natural ostia. And what can happen is they'll often develop a little scar band between the two, which you can see right here. That's pretty much glued shut. And so what happens is if the cilia are constantly moving a blanket of mucus out through that opening, it goes out through the natural opening and then it pops back in to the surgical opening. So we call that a recirculation defect, and it is very easily remedied by just opening up the natural ostia. And typically what you do is you break that, you open the natural ostia and then you break the scar band between the two of them, so you can't have that recirculation anymore. And I think the same was true on this left side. Yeah, it's pretty clogged. There you start to see it open. There it's clogged again. So that might be the scar band that divides the two. And then boom, we're into the surgical ostia. So these can be confusing because at first glance you're like, oh, they're wide open. There's not much we can do to help this patient. But if you look closely at the ostia, sometimes the surgical ostia and the natural ostia are not one and the same. And then the other thing that we see a fair bit are patients who have had fesses and the ostia is perfectly open, but they have a lot of thickening. I think, yeah, let me pull that one up. So this is kind of the chronic sinus person that is, we call them the sinus cripple because we're helpless with these patients. Let me see if this is right. Yeah, so this patient has good openings, little scarring here, lots of thickening, and there's nothing we can do surgically with these patients. I think the one thing you want to do is to culture frequently, because they grow all sorts of weird stuff, and try and use topical antibiotics with these patients. They're wide open, so it's easy to get the drug into the sinus cavities. And these people are taking antibiotics, 6-10 times a year. They're always on oral antibiotics. So culture-directed therapy with topicals. The topicals don't always work, so it's not like you can't go to an oral, but your best bet is to start with topicals. And then we have been experimenting a bit on some of these patients with concomitant allergy and using biologics and thinking, well, maybe. So the jury's still out. We've got a couple that we're trying it on, certainly not indicated, but if they have a polyp, we can usually get it approved. And I mean, nothing else is helping these people and they're miserable, so hopefully we'll find something. Yeah, that's right.
So it's just kind of another thing that we can think about adding inside of
Yeah. Yes, and we talked yesterday, we're going to try and roll that out. I don't know if Megan is here, but we tried and failed and couldn't get the equipment, but
we perform chemical qualities and modification center. That's where we use different chemicals inside the neostromacin, and alcohol, and spray it into the nasal passages 10 seconds each time, and actually help the ciliary dysfunction because the ciliary is actually functioning with that function that is not using up and out. So then they're not always using on antibiotics all the time. And most of our patients use certified and most of them use the test for those too.
What's that combination again?
It's that neostromacin, and alcohol.
so this was brought by, yes, he's going to do it on himself now. Yeah, so I couldn't find much in the literature. We had another ENT physician that was doing this in Albuquerque, and he's from Canada, and I guess this is just a really, really old ENT therapy that I couldn't find much about in the literature, but they've had good success. I've never done it. I've never even seen it or heard of it until he introduced it to me. So anyway, we'll give it a try.
Is there a role for vasoconstrictors ever prior to doing a CT?
Well, usually you're doing it after your endoscopy, so they're going to be vasoconstricted. I'd rather them not be vasoconstricted for a CT scan, because what will happen sometimes is they'll have giant turbinates. You put some Afrin in their nose, they won't have giant turbinates, and then a company like United Healthcare will say, oh, you can't touch the turbinates because they're decongested.
The vasoconstrictor won't affect the papilloma or...
Correct. That it will not. Well, not substantially, I wouldn't think.
I know the Kurtz first is probably biofilm.
Yes, it is.
And I know that the shampoo deal was used for a while, maybe in desperation, occasionally still. Is there anything on the horizon, some sort of urgent or something that will break those up? Do you have to go in and remove them surgically?
Yeah, we used to use baby shampoo, and then we started to see the rare instance of permanent anosmia afterwards. So most of us stopped doing it. There are cases where they're just so bad and they probably can't smell anyway that it's not even a risk. But yeah, there's so much research into biofilms, but nothing has come to market. It's mostly just physical disruption. I tried for a while with compounded gelatinous antibiotics where I'd squirt them. It's usually in the maxillary sinus floor. That worked a little bit, but it wasn't anything to write home about. But if you could get an antibiotic just to sit on the biofilm because they protect themselves. They create, I think it's like a polysaccharide matrix over themselves so that the antibiotics won't penetrate them. Yeah, you strip out that mucosa and let a new layer grow in. Yeah, that's right. There's a reason that's there. It's usually ciliary dysfunction that starts it off, I think. You know, you get bald patches in the cilia, then you get stasis of the mucus, and then it just gets colonized by bacteria.
All right, I know we have more questions, and Dr. Thompson will be available afterwards to answer some of those, but I want to make sure that we keep ourselves on schedule. And